Good evening and welcome to our seminar tonight on the topic being ADHD, something that's very near and dear to probably most of the hearts of every school teacher and parent in America these days. It seems that so much of what we encounter involves this diagnosis for children and for teens, and in many cases, adults. So it becomes very important to try to gain a little bit more of an understanding around this concept. Now, we know that in these circles, in these times, we see individuals classified now as having ADD and those having ADHD. And some of us have thought in the past, oh my gosh, what's the difference? It's all just sort of the AD thing. But certainly the idea of hyperactivity is kind of separate and distinct from simply inattentiveness. And then to make life even more complicated, we see that there's really a spectrum of the two. There's an inattentive type that we just spoke about, but they can also be somewhat hyperactive, but maybe not so hyperactive that their school and grades really suffer tremendously. Then there's the other type, where you will find such an extreme distress in behavioral challenges that academically they just suffer tremendously. So the idea behind nomenclature and what is ADD and ADHD has evolved over time a little bit, but what we're clear about is that they have really, really detrimental effects, not just from an academic side, but a social side. Because what is little junior or juniorette but our future, our hope, our love, our pride and our joy? And we have visions of Harvard and Yale and Oxford for our kids and just doing extremely well. And when we find out that they're having difficulties, academic challenges, for example, then all of a sudden we have a great deal of consternation. And we start to really become concerned over the future of our children. And we know as parents that we sit up sometimes very late at night wondering, oh my gosh, my child just has a cold, or my child just was really, I want to strangle them today. It has ramifications in our social world, in our social network. But as far as our children are concerned, we're also thinking, well, what about their futures? So now when we bring diagnoses of disorders like this into play, we're really looking at an entirely different spectrum. Why? Because it starts to affect our teachers, and our teachers are sending home notes. Our teachers are then calling us in. Little Johnny doesn't pay attention. Little Johnny is running around all over the place and won't sit down. Let's just be fair. Little Jane, on the other hand, won't listen. She keeps talking out the window. She's speaking to people that, are just trying to mind their own business and get their schoolwork done. So that begins to take our time as parents and our time as educators, and then the system becomes involved. And unfortunately, far too rapidly, our teachers are saying, you know what, let's put them on medication. Let's start with, I always say I don't want stock in these companies, let's put on Ritalin or Strattera or Concerta or Vyvanse or whatever it is that's out there that we would use for ADHD. Okay. These are the things that we typically hear. Now, on the side of diagnosis, well, some people would say, I kind of think this whole thing of ADD, ADHD is overly diagnosed. And there may be a little bit of truth to that. There may be a great deal of truth to that. But the real difficulty becomes when you assess a child or assess a patient. And what you see is that, grades have really suffered tremendously. Behavioral challenges are making things very difficult. And the child tells you, I just can't seem to focus. Okay, that's a biggie. And it's no longer somebody else's observation. It's now the patient telling you directly. What about the adults in life? We talked about the children. There are many adults who say, well, listen, I've had ADD or ADHD for the longest time. I just didn't know what it was when I was a child growing up. I kind of barely made it through high school, and I struggled. And, I didn't go to graduate school. And so I had these difficulties, and now that I understand more about this condition, I realize, all this time, this is what I had. So now I'm on medication for it, and, it seems to be doing pretty well. That tends to be another sort of test for whether or not somebody really has these conditions. The idea is if you give them a medication in the traditional world of medicine, and they do better, significantly better, then they really did have this condition that we call ADD or ADHD. Okay. But the other side of the issue is now, this is a disorder that we gave a name to
based upon symptoms. But is it really just some sort of construct that is out there involving the mind, as we say? Or is it something a little bit more deep than that? Is the actual structure of the brain or the interaction of nerve cells at fault, either partially or wholly? Because in the world of psychiatry, what we call a psychiatric disorder is something that, well, you can run every test that you know of and find no answers. And therefore, it's got to do somehow with processing the brain. It's a psychiatric disorder. But on the other hand, what if you can actually test for challenges or imbalances and you find some? And when you treat these imbalances, people improve. Is it any longer really a psychiatric diagnosis? The answer to that is no, it's not. Okay. Now, these are really the definitions that we use in medicine to guide us in certain directions. For example, on a totally different topic, if somebody is depressed and has a low vitamin D level, and then you fix the vitamin D level, and they're no longer suffering from depression, did they ever have absolutely major depressive disorder? The answer is no. Any doctor would tell you that. They had symptoms of depression, okay? But that was not their diagnosis. So now let's move a little bit away from the whole diagnostic phenomenon here and talk about some of the things that we do in the world of biochemical evaluation and distinction. What we've discerned and determined over the course of really 35 to 40 years is that individuals across the spectrum of cognitive disorders have biochemical imbalances associated with them. Many individuals have copper toxicities or zinc deficiencies, or perhaps even methylation disorders. And we'll talk a little bit more about methylation a little bit later. But there are biochemical components that we're seeing now associated with a lot of cognitive disorders that before we really had no clue and we just kind of scratch our head about. Well, you have depression, but we don't know anything else about it, so let's just take some medication. Now, while we're talking about medication, let me just say, some people do need medication, and some people respond very well to medication. We're not adverse to medication. But what we're looking at is what are some of the other parameters that we haven't touched at all, or examined, or even just paid any attention to. Let's dig a little bit deeper to see what are some of the challenges that we can actually deal with that maybe don't require medication, or a synergistic program between perhaps nutrient therapy and medication might prove to be an even better result in terms of at least partially helping to fix the problems that are there that lead to the disorders in the first place. So let's talk about that. On the side of biochemical individuality, every single one of us here is a different biochemical person. Now, overall, we're all sort of the same generalized creature. We all need sodium, we all need potassium, we all need fluids, we all need electrolytes. That part doesn't change. But what about the idea that if something goes wrong in the development of a human being, or in the processing capacity of a human being, that it might be unique to that person? And what we've seen over the course of time is that that is absolutely true. That's why, even though when you've got twins, for example, you ever notice sometimes one twin is maybe a little bit taller than the other, or heavier than the other, or maybe just plain old personality differences? We've all seen those stories on the Lifetime channel, and I don't get sued for that one. The evil twin. You know, the good twin dies, and the evil twin takes over the life of the good twin. And people say, wait a minute, you don't quite seem to be the same person I knew before. Okay. Same physical structure. What looks like on the outside, they should have the same genetic structure and the same genetic manifestation of that program that was built in. But they're not. There are biochemical influences and physiological influences and environmental influences that turn that same genetic blueprint into a different physical, emotional, and behavioral creature. Yet they both started from the same egg. That's the idea behind identical twins. So we are intrinsically and extrinsically different for different reasons and sometimes at different points in time, depending on what's going on in the environment. This is the realm of what we call epigenetics. We're seeing that our genes or our genetic markers can be shifted by environmental influences. We're seeing that with post-traumatic stress disorder, PTSD. We're seeing that with anxiety. We're seeing that with schizophrenia. A lot of disorders we're seeing what? People were fine up until a point, and then oftentimes some environmental trigger shifted their capacities. Okay. The idea here is that it's not simply about genes, and it's not simply about the environment. There's a combination of the two that are simply working together, sometimes for the benefit of the individual, and sometimes for the detriment of that person. But this was really to go to talk about the idea of biochemical individuality. Let's get back to the core piece here, ADHD and ADD. When we're looking at testing, what we're really trying to see is what is sort of out of balance. What is not really working right here that leads to these particular challenges? We know, for example, that a metal in the system, like copper, should be removed in excess from the body by natural mechanisms that are present within the body. Same thing for like mercury, same for a lot of different metals. And you know what, for the most part, our bodies do a great job of getting rid of toxins we never even knew we had. Okay. The difficulty is, what happens if those mechanisms slow down or break down, and we get a buildup of these toxicities? You know, we always think that for some reason we're pretty much just a perfect creature, and nothing really breaks down until we're like older. Okay, maybe a couple years older than me, for example. Okay, but that's not necessarily the case. Many individuals are literally born with challenged capacities to take care of problems that should naturally be eradicated. The individuals who biochemically cannot get rid of certain metals. For example, copper. Back in 1942, a study was done where they put about 5 milligrams of copper in a petri dish with a nerve cell. That nerve cell lit up like no one's business. It was like the nerve was on speed. It was just supercharged. So we found out from that study, really, that the effect of copper on the nervous system is hyperexcitability. Okay. So now, what about that, and what does that have to do with ADHD? Well, one interesting mechanism behind one subtype of ADHD can be related to metal dysmetabolism. The idea that copper, for example, as an element, can influence neural activity to the point of hyperactivity is actually very well documented now in our studies. So the idea of, well, we know this, but can we test for it? And the answer is yes, we can. We can test for a variety of elements that can influence hyperactivity or inattention or focus or anxiety in a tremendous number of patients. And the database that the Walsh Research Institute has, it covers over 5,600 patients with ADHD, and it's broken them down into inattentive types, hyperactive types, and those individuals who are sort of a combination of the two, but neither of the extremes. And some very, very interesting research phenomenon have been seen with regard to each one of these conditions. One of the subtypes, for example, has an extreme copper-zinc dysmetabolism. One of the things that we know is that copper and zinc tend to balance each other in the system. But when you have too much copper and not enough zinc, you end up with copper predominating in the system, and kind of like sticking an electrical wire into an electric socket without the proper insulation. You get short-circuiting of processes. This can often lead to that idea of either inattention or hyperactive behavior. Other individuals have very, very low zinc levels and therefore can't regulate gamma-aminobutyric acid, one of the calming neurotransmitters that's present in the brain. Now, it's not necessarily one or the other. It's usually a combination of imbalances that are present. But what we're seeing here is that from a metal side, there are definitely issues with regard to metal regulation or dysregulation present in the systems of many individuals with ADD or ADHD. Another aspect involves methylation. Methylation is really the capacity of the body to activate, turn on, turn off, suppress enzymes, hormones, neurotransmitters etc., different chemicals, by way of methyl groups. Now, a methyl group, this takes us back to general chemistry, when I didn't think it was even important to pay attention. A methyl group is a carbon with 3 or 4 hydrogens associated with it. What we didn't realize was the power given to a methyl group. These little groups can radically alter you, your perception, and your behavior, and in some cases, believe it or not, the actual job that you get in the future. We know that individuals who have very few of these methyl groups tend to become very perfectionistic. They tend to have a great deal of the idea of paying attention to the dotting the I's and crossing the T's. And what does that usually mean? It usually means that you tend to get better grades, because you're not happy if you got a B+. The question is, why didn't you get the A? Okay. And they tend to be very, very persistent in trying to excel. These individuals will often go to graduate school and they'll become what I like to call the Ds, the PhDs, the MDs, the JDs, the engineers, high-pressure salesmen. Very interesting people are often what we call under-methylators. They don't have these methyl groups, and so these pushy perfectionistic tendencies are always there. And forgive me if anyone out there is a salesperson, I'm not saying you're pushy. I'm just saying that perfectionistic tendencies seem to be present in these groups. Now, there's the other side, where you can have too many of these methyl groups, and you can be considered what's called over-methylated. These folks tend to be a little bit more laid back, and in many respects, they're kind of the opposite of the under-methylators. Not that they can't get good grades, but their approach is a little bit different. They kind of sit back and take it easy about things. They're very laid back. They're your smooth jazz, easy listening kind of folks who kind of take things in stride. But at the same time, in order for them to get a thrill out of life, these folks engage in very extreme behaviors. These are the guys who are going to get on that motorcycle. They're going to jump off the Grand Canyon, and they know they're not going to make it to the end, but that's why they've got the parachute, so that they can then sort of parasail the rest of the way down the Grand Canyon. That's what gives them a thrill. Me just watching it on TV, that's enough. I don't have to actually do it. Okay? But the idea here is that methylation can drastically influence your life and your behavior. And we see in another subset of individuals with ADHD that methylation, both under and over, play an important role. Now, I want to make that distinction now that we've spoken about over-methylated and under-methylated individuals who have this categorization of ADD or ADHD. Many in medicine right now will tell you that, quite honestly, there is a subcategory of person with ADHD, supposedly, who is really an early presentation of bipolar disorder. Okay. The difficulty was that quite realistically, until Dr. Judith Bowman of Mensah Medical did an evaluation of several biochemical elements, that she determined that it's the over-methylated population that perhaps is really that crossover bridge to pre-bipolar disorder in individuals who were previously thought to have ADD or ADHD. That's a very important distinction. Important because of diagnosis and important because of treatment. Because for a while we were kind of sitting back and saying, hey, you know what? Well, you're ADHD, but watch out. You really could be bipolar. We won't know for a few years. When that happens, you come back and we'll talk about it at that point in time. Okay. Well, no. With testing, we can determine the methylation status of an individual, and that can help guide us into the direction of whether or not somebody really might be manifesting bipolar type symptoms later on. That also has a great deal to do with what kind of treatments do we give to this individual who may be over-methylated versus this person who's under-methylated, while they both share the symptoms of ADD or ADHD. So a great deal moves to treatment with regard to biochemical analyses. Now let's make your lives even more complicated. What about the individual who has all these biochemical imbalances and they're all together? Well, quite often I say these are the ones that are probably having the greatest behavioral challenges, not just inattention, not just a little bit of hyperactivity, but mood irregularities, behavioral challenges. You can't seem to get a grip on these people, and they're very flustered. They're very angry. They're frustrated because They know something's wrong, but they can't seem to do anything about it. Okay? So there's this idea of the concept behind nomenclature, the names ADD and ADHD. What we've seen thus far is that that doesn't really go deeply enough to tell us about these disorders. We're seeing that there are biochemical abnormalities that are also associated with these disorders. Each biochemical abnormality that's associated oftentimes is very, very treatable, and individuals do better. Okay? I don't like to say we cure anything, but moving someone from one state to another is precious. Talk to the mom who nicknamed her daughter the Shredder at age 6, because every time she came across something in the household, she'd have to rip it up. Okay? And then with treatment and therapy, that child no longer shreds. One less piece of anxiety for a mother, be it a single mother or a married parent, to have to deal with regard to the difficulty of a child. Difficulty of raising a child, not the difficulty of a child. We know how difficult parenthood is in general. Okay? So minimizing behavioral challenges in children with these diagnoses, or even you as an adult, you can understand that's a lot less work for you, trying to keep yourself focused and trying to keep yourself attentive, than if you are still struggling with these challenges without treatment or therapy. Let's move on. Let's talk about, well, Dr. Mensah, how on earth do you find out what kind of biochemical imbalances you may have, or whether or not you're that, what do you call that thing, methylation thingy? Well, there are tests for that. Now, we use a lab called Direct Healthcare Access to Labs, and they help coordinate the specific biochemical testing that individuals need. Okay? So the first step is, of course, finding out what the challenges of any given individual happen to be with ADD or ADHD. Is it simply a little bit of inattention? Is it problems with focus? Is it something that's behavioral in terms of erratic behavior, or is it far more extreme than that? Step number 2 then. Well, quite honestly, we also look at genetic histories. Tell us about your parents, your grandparents, your cousins, your aunts, your uncles. Did anyone have any kind of disorder that might be involved in methylation? We see that many children who have ADHD or individuals with ADHD had family members who've got other methylation disorders. Some have autism. Some have Alzheimer's disease later on in life. Some have OCD. Some have ADHD in the family. All of these tend to be related to methylation disorders in some way, shape, or form. Now, I'm not saying they're purely caused by methylation disorders, but there's an undercurrent that runs through family lineages in this fashion. So testing becomes very, very important. Now, the next side involves treatment. Now, the most important thing to remember is that, of course, there are traditional ways of dealing with any of these conditions by pharmacological therapies. There are the drugs that can be used, and some individuals will need them. Some individuals do very, very well. But on the other side, there are actually more natural ways, we call it nutrient therapy, to deal with many of these imbalances. You can target the given biochemical imbalance that's present with nutrient therapy and help to shift the balance from either being in excess, for example, like too much copper, or deficiency, such as too little zinc, into something that is more appropriate for the body to use. What we didn't mention thus far is that the brain is basically a biochemical factory for our purposes. If it doesn't have the right concentrations of certain elements, it can't make the appropriate levels of balanced neurotransmitters. It can't make the serotonins, the dopamines, the norepinephrines, the gamma-aminobutyric acids, all those wonderful neurotransmitters that keep us happy and balanced. It can't make them in appropriate numbers or concentrations. So how about rebalancing that brain chemistry and letting the body take over from there? Give the body what it needs, and hopefully we'll be able to regulate or re-regulate the system, kind of like jump-starting it back into normality. Okay? So that's really one of the big pushes that we're looking at here. Let's not just and only use medication to treat these disorders. Let's look at the causes or potential influences that are present here and treat them by way of natural processes. Okay. One of the most interesting things a patient once said to me was, Dr. Mensah, I just don't understand. Much of modern day science looks at us with a great deal of scorn when we suggest that using a natural molecule should help fix the problem, when they're trying to use unnatural molecules to fix it as a solution. And I said, you know what? You make a lot of sense. The body recognizes this and says, hey, we're not going to have much side effect profile here versus this other side where we can see a lot of side effects. Now, don't get me wrong. Once again, many people actually need both or at least do well on one. So that's not a huge problem. But our idea here is let's look deeper into some of the potential causes or the influences that are present in either one of these conditions. Now, before I forget, there's one thing I do want to address, and that's a very disturbing trend that we're seeing with regard to medications. Now, it's not involving the companies that produce these medications, and it's not entirely the doctors who are prescribing these medications. It's the undercurrent of what I call the ultra gunner student, the one who is so extremely competitive that they're looking for any competitive edge. We've seen a disturbing trend amongst college students now to seek these medications in order to use them the night before an examination or the week before an examination because they're trying to get an edge on not only the competition, but perhaps even just for themselves. Okay. Do they have ADHD? Absolutely not. Do they have ADD? Absolutely not. But you know what? They're thinking, how can I get an edge here? Do you know what we would otherwise call this phenomenon? Drug abuse. Okay. The difficulty is that as we sit back in our mortal busyness as physicians, we see someone come in and they say, you know what, I've got ADHD. We'll go, okay, here you go, Concerta. It's become so routine in our world that we're not spending enough time truly assessing what's going on here. Does this person really have ADD or ADHD? Have they had a history of this in their lives? Did it start in childhood? Because usually you don't just acquire ADD when you're older. Okay. Yet a 19-year-old comes to us and says, listen, doc, I've had this stuff for a long time here, and I kind of want you to help me out. I've got exams coming up, and, I ran out of my prescription. How often do we as doctors check to see if you ever really had a prescription? You'd be surprised, maybe you wouldn't be, at how many doctors are not looking back at those histories. Now, I'll be quite honest. As doctors, our right-hand person tends to be our nurses, okay, and our staff people. They are awesome. All you nurses out there, we love you to death, okay? We love you to life, too. But if, for some reason, they didn't check the history or pharmacy as a backup to us not checking, then we're more liable to just say, here you go, here's a prescription. So now we're giving these prescriptions out to individuals who don't have these disorders. And then problems ensue later on. This is not appropriate. I'm not saying that it's purely the doctor's fault. We're human too. But the idea here is that here's a phenomenon that's out there. And if we spend a little bit more time with regard to each patient, with regard to checking on what this phenomenon really is and this condition really is, and the real necessity for the utility of medications, we might all be in a better place. And by the way, if you really do need to increase focus, there are natural remedies to do just that don't have any effects or side effects that the drugs do. So you don't have to go out there and look for a drug dealer, okay, with regard to any of those medications that I've mentioned. There are other approaches that can be taken. Okay. Now, I don't want to flood 1,000 phone calls from college students saying, where can I get that stuff? It's not going to happen, okay? But we're just sharing with you that there's a different approach, and we don't have to move in the wrong direction as physicians and practitioners. Awareness is key, and once you know, you're in a position to do. So now that we understand we've got these other arenas involving biochemical elements, mixing with environmental and genetic elements, now we can look at our approach more comprehensively, as opposed to simply saying, here's a symptom, here's the treatment, go your merry way. Remember, it can be a very positive thing to perhaps not have to be on any medication, or can be a great real reality check to say that, you know what, you do need some medication, but here are some appropriate nutrients based upon your chemical evaluation that will help improve your life and shift it in the right direction. I'd like to open the discussion for questions that we have at this point. Well, anytime you've got newer therapies or newer processes, it takes a great deal of time to trickle down into traditional medicine.
It's been going on 35 and 40 years.
That is absolutely correct. But you know what? Sometimes it takes 50 years just to get the newest thought into mainstream medicine. And part of the reason is that, firstly, the ideas tend to come from researchers, for the most part, not doctors. Now, the researchers then publish this information, and it may sit in a journal for 10, 15, 20 years. And then some doctor somewhere will pick it up and think, hey, you know what? This is a great idea. Maybe we should test it. And so now you get a research grant together for clinical testing and evaluation. And by the time that's been published and moved forward, and then it's now put into practice, you're saying this really works pretty well. But now then you've got to get it into mainstream medical education and have it trickle down. All these things take a very, very long time to do. Now, the blessing that we've had is that as a physician group, we've worked with the researchers in one environment. And so new ideas and new therapies get scrutinized quite heavily. And then we look to perhaps put them into therapeutic trials. Of course, we do the appropriate research with the appropriate biochemical elements or other trials before we do human trials. But when it's deemed safe and considerable, we can now implement these therapies very, very rapidly. The difficulty is that we get it, those we train get it, but moving it into the realm of medical school and medical training takes a much, much longer period of time. Now, that's just one side. Let's talk about the other side of being the doctor and humanity, which is that, quite honestly, sometimes we're very egotistical, and we don't want to listen to anything that seems to be new. One of my favorite stories involves Dr. Lister, the man who came up with the idea that these little tiny microscopic things called bacteria that can actually cause disease in individuals who just had surgery. But guess what? The doctor didn't clean the surgical instruments in between the time that he used them on one patient and another one. Now, to us, that seems like a shocking, archaic idea. But once upon a time, this is how surgery was practiced, until Dr. Lister came along and said, you guys, this is not a good thing. But the surgeons kind of looked at Dr. Lister and said, Dr. Lister, let me get this straight. So there's this invisible, little tiny microscopic thing that we can't see called bacteria that actually does harm. Come on, Doc, let's get real here. Until someone paid attention and said, let's clean our instruments. And you know what? People lived. So now that became further evaluated, and the whole world of bacteria and bacterial invasion and bacterial detriment was just increased tremendously. It takes time to get through the filters, is my long-winded way of putting it, but in time it will happen. We're seeing this spread across the world now with a great deal more interest. Not just are we training doctors in Australia, we're also training doctors in the Philippines, doctors in Ireland, doctors in Scandinavia. Doctors in Egypt would have been on board, except Egypt seemed to have a little bit of trouble these past couple of years. And I'm not going to comment on that. It's not a political discussion. I don't want anyone to be offended. But the idea is that this construct is spreading around the world. And it's not just some wacky doctor somewhere with some crazy idea that has no research behind it. There's plenty of research behind what we're talking about here. Plenty. And it's been going on since 1940s. Okay, it was really sort of metered out and fettered out extremely well by the work of Dr. Carl Pfeiffer, and then by the work of Dr. William Walsh. It's just blossomed and it's spreading tremendously. But we are the wonderful recipients. We are blessed to be able to have this methodology and to understand these concepts at a different level than what traditional medicine has to offer. We're not the only ones, but right now we like to say we're the ones who are doing our best to help others do their best. We consult with other doctors around the country and literally around the world. We get emails. Dear Dr. So-and-so, I've got this patient. What do you think about this particular chemistry? And how would you go about it? So what we're hoping is that, as stubborn as we are in the U.S., we know that quite traditionally, it may get all the way around the world, but it'll come right back here. And someday, some group is going to say to some group abroad, where did you guys hear about this? This is great stuff. And they'll say, wait a minute, it started in the United States. What are you talking about? And they'll go, really? Well, I guess we better catch up to the rest of the world. So I hope that wasn't too long, but every now and then I tend to tell stories every time somebody asks one question. So I apologize for that. God bless you. Now, here in this country, though, it's not quite simply an environmental phenomenon. Okay? There are actual biochemical challenges that are present, as we talked about earlier, that are truly at the root cause here. But let's talk about social habits. One of my pet peeves, I hate to say it, is a lot of the allowance for extracurricular time being spent with very fast-paced, motion-filled, active-laden products. I'm going to get in trouble with the video industry here, but you know what I'm talking about, okay? And we allow our kids to simply program themselves to not be able to pay attention for more than a couple minutes at a time, okay? You can't sit around and just be at peace. Remember the old days when you're driving the back of your parents' car, you just kind of sat there, staring, looking out the window. You developed a great imagination, because while you're driving around the country and seeing nothing but flat plains and grass, you had to do something with this brain up here. Well, nowadays, we travel for 5 minutes down the street. We've got to have the back of our cars, with the seats anyway, with video screens for our kids. They've got that going, while they've got the little Game Boys going, or Game Girls, or whatever is popular these days, and cell phones, et cetera, et cetera, et cetera. Listen, some of us have initiated mandatory no electronic device hour, at least, in the house. And I'm not going to just talk about the kids. Sometimes the grown-ups, it's like, you know what, give me that iPad. Enough already. Okay. We've lost the social dynamic. I'm not even going to go there. But the idea here is that oftentimes our children are really learning to have a very short attention span. Very interesting study done on the structure of the brain in children and adolescents these days. There's an area called the homunculus, okay, which is really sort of showing us which part of the anatomy is sort of controlled by which part of the brain. And when you look at sort of the middle side of the brain, now there's an area that controls literally the hands, the arms, left and right, and each one has a very particular orientation and size. You know what's really interesting about this segment and study in today's kids and adolescents? That area that controls the thumbs is much larger. This is not a joke. This is true. The area that controls the thumbs is gigantic as compared to what it used to be in someone like me. Of course, I'll tell you, I can barely type. At today's age, that was the biggest joke when computers came around, because, anyway, that's another story. But quite literally, our activity level is changing our brain structure. And thumbs and control of thumbs is now a much larger section of the brain than it used to be. Okay? This is what we're doing in our culture and our society. Now, on the other side, my thumbs are really too big to kind of just, work these little tiny devices. I kind of have to use a stylus. So my it's probably really small. And many people out there thinking, yeah, doc, your brain is probably small too. But that's sort of beside the point. There are structural changes that are occurring in the brains of our children because of programming. That's really sort of the bottom line here. And what may have been just a tendency is now turning into a full-blown disorder, because in many cases, the environment, video games, etc., is now mixing with that chemistry, and it's becoming much larger than if the environment were different. Okay? Well, actually, it starts with a very in-depth history. Like any medical environment, you want to do a history and a physical examination of the patient in question. Okay? And you want to make sure you rule out certain disorders. Now, a certain subset of people that we thought have ADD or ADHD have a thyroid disorder and never knew it. And the interesting thing is that many times you'll be checked for a thyroid disorder and you're fine. Okay? But then there's this window period where you're saying, well, I don't know what the problem is. I just saw the doctor 6 months ago. It can't be my thyroid. I was checked for that. You know what's interesting? As doctors, many of us will say, okay, that's fine. But I learned something the hard way in a member of my own family. She was having anxiety issues. She was checked for thyroid by several doctors. Time went on. 6 months went by. A year went by. I, in my own wisdom, decided, well, we've already checked her several times for thyroid disorder. Why should I check her again? Okay. Turns out she was extremely hyperthyroid. She had lost a tremendous amount of weight. And this is my aunt, rest her soul, she's passed on now. But the lesson I learned here was don't assume that there are no other reasons or causes for anxiety or poor focus or agitation or any of those things that you can see in ADD. You check all the bases. So we'll do a history and a physical examination. And after we've checked that history, looking for things like other possible methylation disorders that are showing up in relatives, we mentioned earlier, then we start with the testing. So our testing will be regarding traditional elements like a complete blood cell count and comprehensive metabolic panel. We'll look for things like thyroid disorders, vitamin D deficiencies, etc. And then we'll do very specialized testing involving very particular biochemical elements that are possibly contributory to the disorder of ADD or ADHD. Okay. Once that's done, we'll get back all your test results, and my partner, Dr. Bowman, and I, we've worked together on pretty much all these cases. We'll sit down and fuss at each other with our professional opinions to determine what is going to be the best method for you, the best treatment protocol for you. When we do that, we will then put together pretty much what you consider your own personalized nutrient protocol to be taken on a daily basis to help shift your chemistry. Now, 6 months from that time, look to recheck those chemistries because you know what? Here's the objective side of this. We can actually follow your improvement. We can actually predict your doing better or worse based upon what our chemical testing shows us now, 6 months from now, a year from now, a year and 6 months from now, or when you enter a stressful environment. The chemistries change and we can use those as predictive values and guides to our therapy. We do not create a treatment program based purely on symptoms. From my perspective, and I'm going to say it, that limitation is what gives us the big question mark in traditional medicine with regard to brain disorders or mental health challenges. Because how many ways can you have anxiety? Okay, anxiety is a symptom, but we've created it and turned it into a diagnosis. But the fact is there are several different biochemical subtypes that produce anxiety. So we want to make sure that we're using not just symptoms, but we're also using objective evidence in terms of testing and objective numbers and numerical elements to give us the appropriate approach relative to just not which supplements or elements to use, but which concentrations to use. And it's all directed and targeted to your individual chemistry. Not even your twin brother, if you had one, would be able to use it because your chemistries would be different. Okay. We then follow up, usually in the first 6 months, then the 1 year period, and then usually by that point in time, individuals tend to be on cruise control. And then it's a once a year kind of follow-up sort of a deal. You may ask, why that particular time frame? Well, it took you 9 months to develop in utero, your mother's womb. It took you another 9 years for your brain to start to really mold and solidify into adult processing. To change chemistry, it takes time. It doesn't happen overnight. And we've seen with our testing and with years of experience and evaluation and research that usually anywhere between 3 months to 6 months is a good time frame to look at the progression of change with regard to chemistries. So that's why we test at 0 and 6 months initially. Actually, that's a very interesting question you bring up, and yes. Now, what we didn't talk about earlier in our discussion is this concept of pyrrole disorder. And I didn't because I like to talk about pyrrole disorder a lot. Pyrrole disorder can be seen in a multiplicity of disorders, everything from anxiety and depression to schizophrenia to bipolar disorder. Many individuals who classify it as rapid cycling bipolar are actually being misdiagnosed. If you did a simple test for pyroles, you would see they're pyroluric. And what is pyroluria? It's a deficiency where a molecule in the system that we all carry, called a cryptopyrrole, it's part of our heme molecule that carries iron throughout the blood. This same molecule is really a reference marker for what we call oxidative stress. But this molecule, if present in large numbers, will strip the body of two very important elements that are needed for the production of balanced neurotransmitters. That would be zinc and vitamin B6. When that happens, what are some of the symptoms of pyrrole disorder? I know you're thinking that. Thank you for asking. Rapid cycling mood shifts. You can be calm one moment, angry and hyperexcitable the next moment. Those shifts can occur for days at a time. Those shifts can occur moments at a time. But the key here is that that imbalance can make people either able to focus because they're calm for a minute, or not able to focus at all because they're in that angry, hyperexcitable, rageful, or just sad, or just moving all about mode. But if someone has pyrrole disorder, that's a very potentially strong component to their ADHD and can be present with it. Those individuals, that aspect can actually be very well treated, usually within 3 weeks to 3 months. That's a great question. The simple answer is they're not specific to Mensah, if you want to call that, to Mensah Medical. But we don't just say, here, go find these medications, these supplements out at Joe's, pharmaceutical shop. Okay, we actually create a very specific combination for you that is a prescription form. Okay, it is the prescription for your particular chemistry, as I said with this gentleman here earlier. So from that side of it, no, you can't just go out and shop for it on your own. Okay, as a prescription, we kind of direct that this is needed. Now, many individuals can take that prescription and go to their pharmacy of their choice. But we have a pharmacy that we like to work with that has extremely high-grade, high-quality products. And I'm not going to say that because I don't want to sound like a marketing tool here, but we do work with very particular pharmacies because you have to be careful about accuracy, but you also have to be careful about the purity of the product. I hate to say this, but the world of nutrients and supplements is full of a lot of questionable elements here. Okay, and some things are gotten that are absolutely toxic. Some things are gotten that are impure. They're contaminated. The places that we work with, we've actually been to their facilities. We've seen their wash down capacities. It would absolutely amaze you to what degree of minutia and just their entire meticulous nature there. If something is off by one microscopic element of danger, they will shut the whole process down, clean everything in like little tiny white bubble spacesuits, okay, and start all over again. That's the kind of purity we're looking for, because if we don't have the right products available for you, or the right nutrients, in the right capacity, with the right purity, you don't get better. And then we look like we don't know what we're doing. But more importantly, it's you. And we want you to do better. Great question. No, nutrients are still needed. And the reason why nutrients are needed is because while we're getting smarter in our scientific field, we don't yet fully understand how to fix the gene. It's the gene mixed with the environment that's producing the proteins that are problematic. While we can't fix the gene yet, at least as far as I know, we can work against the tidal wave of activity that those proteins that are made from the gene are engaged in. And so in order to keep, so to speak, those proteins in check, this is where the ongoing nutrient therapy is required. Okay. So while this protein might lead to a domino effect that says poor focus, now we add basically our focus program to combat that. So it's pretty much a daily regimen that's required. Deep in my heart and in my mind, I've seen how fast we're moving in the realm of science on multiple levels. I actually believe that within our lifetimes, these disorders will not exist. They may show up, we'll be able to go to the genetic level and fix them. Okay. The way nanotechnology is moving right now, there are research paradigms where people literally have got, well, they don't have them yet, but the idea is that you can produce red blood cells that can carry 4 times as much oxygen per cell. Imagine going swimming underwater for 4 hours without a scuba tank. Okay. This is not mythology, this is real. Okay. So what I'm saying is that we know that with the rate we're moving, someday we're going to be able to go in and fix them, and then I might just be out of a job, but it'll be a great thing to move on to a different venture because we would have been able to take care of people appropriately. Even better, we may get to the point a little bit later where we can test individuals in utero and fix the problem before they're ever born. Now, wouldn't that be just a great sight? But I think we'll get there. So in our lifetimes, I think we won't necessarily need nutrient therapy. Until that point shows up, I say we do. Because that's just where we are right now. But I think we're going to be doing better. I honestly do.